I'll just talk briefly about training in, I'll just put my timer on. So I'll just briefly talk about the training in United Kingdom. Let's go through a few things. We'll just go through a bit of overview of the training, how the medicine works in the United Kingdom. What are the entry routes? Internal medicine, high specialist training, specialty respiratory medicine. What does it look like life beyond training in UK? So essentially, it is a government-run national health service. Okay, it was founded post World War II. It is paid by the taxpayer. It is free at the point of care. There's no charges to you. Most of the services, still 90% of services are free to the taxpayer. If you are a national here, if you are a resident here, you can access those services. There are different institutions that feed into it, such as NICE, such as Public Health England, such as the Department of Health and Social Care. So they all feed into the national service. Its budget was about 160 to 180 billion pounds last year. So quite a massive institution, which comes with its own complexities and problems and obviously perks. So a bit about myself. I graduated in 2011. I'm a graduate of National Medical College, Multan. I did my house job in Lahore in New Hospital. Following that, I did my PLAB 1 and PLAB 2 in 2013, 2014. I came to UK after that. I did my core medical training, high specialist training in West Midlands rotation, that is Central England, and I finished in 2022. Following that, I did a post-CCT fellowship in sleep and home mechanical ventilation. And since October 23, I'm working in sleep and home mechanical ventilation in a complex regional ventilation unit. So for you to practice in United Kingdom, you need to have, you need to be on the GMC register. GMC is the General Medical Council that regulates doctor in the United Kingdom. The registrations are either provisional registration, which is your foundation year doctor, which is equivalent to the house job in Pakistan. Once you've done that, you come into full registration. That is your medical officers in Pakistan. That is post-foundation. And then you come into GP and specialist register. That is following that, who are the specialists who have completed their higher specialist training and can work as a consultant in UK. So the route I took, that was PLAB, that is Professional Linguistic Assessment Board. It is held, I think now it's held in Pakistan as well. It has got two parts. The part one is an MCQ-based question, which has got about 180 questions, and part two is an OSCE examination, which I think is only held in Manchester, United Kingdom. It has got 16 scenarios, which most of them are clinical, communication, and practical scenarios. For you to apply for PLAB, you need to have acceptable primary medical qualification, that is an MBBS degree, and which I think, from what I know, all of the Pakistan medical colleges are acceptable, and you need to have an English language assessment, which comes in the form of either OET or IELTS, and you have to take a test to prove that you are proficient in English before you come and practice medicine in UK. Again, PLAB 1 is set at the base of your foundation year doctors. So for someone who has done a house job, especially in Pakistan, so they ask questions according to that. If you're interested in doing that, there's a foundation curriculum that is available on the GMC website. So please do go through it and give you a basic idea of questions they want to ask. And there's also practice questions available on the GMC website. PLAB 2 is, as I said, it is set at the level of new foundation doctors that are post-house job compared to Pakistan. It has got clinical, practical, and interpersonal skill questions. It is 16 scenarios, and it is held in Manchester only at the moment. Once you've taken your PLAB 1, Plan 2, if you're successful in that, then you can get onto a registrar. What I would recommend, if you're looking to come to UK after especially PLAB, that you make sure you do your house job, because if you don't do your house job and you take your PLAB 1 and PLAB 2, then you will only be able to get a provisional registration. That means that you'll have to get into a foundation program, which is equivalent to house job. Foundation programs are quite oversubscribed and difficult to get into. So it is better that you complete your house job, especially in medicine and surgery, and then you can take your PLAB examination, get a full registration. And what that does is it opens route for different jobs in UK, which do not require full registration. Because if you have provisional registration, you won't be able to apply jobs apart from foundation doctors. You'll have to take English language test. You have to have a certificate of good standing from your from the Pakistan Medical Council, And obviously, if there are any gaps in the inform, you'll have to explain them. Apart from PLAT, the other routes to register as well. If you've done MRCP, Royal College of Physician exams, there are few postgrad medical qualifications, and I don't think any of the qualifications for Pakistan are acceptable at the moment. In past days, it used to be anesthesia, which was accepted. If you had anesthesia in Pakistan, you could be on the register. And obviously, USMLE, Australian and Canadian exams, they are acceptable. That can get into the GMC register. Briefly talking about MRCP1, so it's a member Royal College of Exams. So there are 3 Royal Colleges in United Kingdom. That is your Royal College of Glasgow, Edinburgh, London. They all hold a single MRCP exam. That is held by JRCPTB. That is Joint Royal College of Physician Training Board. The first part is a 1-day exam. It has got MCQ based. It is happening in Lahore and Karachi as well. Roughly costs about 616 to 655 pounds, and the maximum attempts allowed are 6, I think. Moving on, then you move on to MRCP Part 2, which is again similar MCQ-based exam, which is more clinical as compared to MRCP Part 1. And I think it's happening in Karachi and Lahore as well at the moment. Following that, you move on to PACES, which is probably one of the biggest hurdles that people find, especially the international medical graduates. And that is more due to the lack of practice skills, lack of knowledge of how the symptoms system in the world work. It's a half-day clinical exam. They judge your 7 core skills. It happens 3 times a year, costs about £1,200. Again, the maximum number of attempts allowed are 6. Once you've done the MRCP, then you get the diploma, and then you're able to apply to be on the GMC medical register. Medical training in UK has changed over the last 5 years. This is the route at the moment that you can take. So if you look, you do your foundation year training, then followed by your internal medical training, and then your higher specialist training. Talking about respiratory medicine, specialist respiratory medicine starts at ST4. You can do your respiratory medicine with general internal medicine and intensive care medicine. Usually, if you are able to secure a training post in respiratory medicine, it is combined with general medicine. Intensive care medicine is an optional add-on for which you have to go through different interview process, and it lengthens your training by about 1.5 years. But at the end, you get triple accreditation in respiratory, general medicine, and intensive care medicine. MRCP, as I think I've said before, it can be taken up for 12 months post your postgrad experience. It is a bit longer route as compared to PLAB, but it does give you a competitive edge in competitive job market. At the moment, the job market is quite tight. There are lots of people who are looking for a job, but they're struggling at the moment, and it is due to a variety of reasons. And IMGs generally tend to have a lower pass rate. Again, there are a variety of factors involved in that. So when I did respiratory medicine, it was about 5 years. It has recently been shortened to make it a more holistic and generalist, and it is now 4 years now. It is quite competitive. I'll show you some competition ratios in the next slide. So if this is the competition ratio of respiratory as compared to gastroenterology, cardiology, and intensive care medicine. So it means that for every 1 post, there were 3.15 applicants. If you compare it to cardiology, there are about 3.09 applicants. And if you compare to gastroenterology and intensive care medicine, about 2 and 2.5 applicants per every job. So it is quite a competitive specialty. It is quite popular here because it is quite evolving. There are lots of subspecialty interest that you can develop. Training in United Kingdom recruitment is central. It is divided into 14 deaneries, which essentially are regions, and who are in charge of the training locally. In 2023, there were 105 national training numbers, which means there were 105 respiratory registrar jobs, which lead on to consultant jobs. It normally happens in round 1 and round 2 phases. Application normally going by December and offers by April, and the posts then tend to start in the August the following year. It is a combination of university hospital and district general hospitals. You get a variety of experience depending on where you work. You get general respiratory work, you get specialist work. You're able to get your procedural competency, especially in ultrasounds, bronchoscopies, EBUS, thoracoscopies, to name a few. There's annual review of career progression, in which you're judged to make sure that you're meeting the minimum requirements that are needed for you to be a consultant. Once you have to complete your training, you get a certificate of completion of training. You have to pass the exam before that. For respiratory, it's called specialty certificate exam. It is MCQ-based exam. Once you pass that exam and complete your training, you can write post-normal and MRCP respiratory medicine, and then you are eligible to apply in the special register. And following that, you can work as a consultant in United Kingdom. There's been a lot of emphasis on out of program experience nowadays. That's probably because the training has been shortened. There are lots of post-60 fellowship that people are doing, and people are going out of their training as well to pursue specialist interests. It gives you an edge in a competitive job market. You're able to dictate a bit on your own terms and leverage a better job for yourself as a consultant. A few specialties that are very popular. So pleural lung cancer is very popular in the UK at the moment. I think that is a trend globally. I specialize in sleep and non-invasive ventilation, so which is another specialty, and some other are cystic fibrosis, pulmonary hypertension, transplants, severe asthma service, and interstitial lung diseases. They tend to be generally based in tertiary care centres. The reason I chose respiratory, I think it was a case mix as well. It was a procedural and non-procedural specialty. There are lots of acute interventions. There are lots of acute therapies that you can provide that can be quite fulfilling. I have a special interest in sleep-related breathing disorders, meaningful invasive ventilation and home mechanical ventilation. The place I work, we are specialized breathing unit for meaningful invasive ventilation, and we also large pleural service. And obviously, you get to do your procedures, bronchoscopy and thoracic ultrasounds, which you get trained on during your training. So training highlights wide. UK training is quite structured and protected. When you are training, you get protected time to do your training and your learning. There's generally tend to be a monthly teaching that you attend. It is quite competence-based. There's a close interaction with consultants and supervisors. There's no barriers for you to contact them or asking questions generally. There are quite a few learning opportunities, and it is encouraged to have a subspecialty interest so that you can develop on later as a consultant or as a senior registrar. More lately, it has had a few drawbacks as well. It is more focused on general internal medicine, which generally people don't tend to like. The recent shortening of respiratory training has eaten into that. Your experience can vary from hospital to hospital, and there has been a surge in interventionalists, which has dried up few opportunities for people who want to do it but don't want to do it dedicated, as some people do in tertiary care centres. What does future look like? The future, I think, because of the aging population, looks like more generalist. Most of the jobs come with the general internal medicine incorporation. There's more reliance on allied healthcare professionals like specialist nurses, physician associates, and more going forward. I think the subspecialties are going to be concentration in tertiary centres, that is, the large hospitals. We'll probably spell the end of district general hospitals, which has been the trend here for the last decade or so. I'll briefly talk about visa regulation. There has been a few changes in work visas in the United Kingdom. It is more closely regulated. It depends from government to government. Obviously, if you get governments which are anti-immigration, they tend to tighten the rules. It used to be tier 2 visa when I here a decade ago. Now it's called health and care worker visa. It has got English language requirements and employment requirements attached to it. The minimum salary threshold has been increased to £29,000. I'm going to share some links, and you can have the slides as well. These are a few useful links that you can look into if you want to look into the nitty-gritties of all that. And thank you very much for the opportunity to give this talk.